Please take your seats. We would like to start, and I promise you we are going to be more optimistic. Welcome and good afternoon. I am Moshe Mittelman from Tel Aviv, and I am happy to chair and to share my thoughts with my two distinguished colleagues. As I said, a different topic: no mutations, no hematopoiesis, no inflammation, something else. Several months ago, Peter Greenberg approached us in a meeting and asked several people, why do you think we don't have enough effective medications for MDS? And interestingly, everybody said something different, and I myself said, well, I don't know. But as physicians, we were all trained, when we have a problem, number one, to study it, number two, to establish a diagnosis, and number three, to try to offer an effective treatment. So that's what we will try to do today. So together with several colleagues in my team, we were trying to do kind of an exercise, and I would like to share with you these kind of thoughts about the exercise. We try to think, what do we have to offer to 100% or 100 patients with MDS? So you will agree with me, I hope, that several of them are very low risk. They may not need anything except for follow-up, but the others are distributed between the low risk and the high risk. So let's focus first on the high-risk patients. If we take these high-risk patients, several of them will undergo stem cell transplant and might be cured, and the others will probably be offered venetoclax and one of the hypomethylating agents. Now, if they have no response, and almost 50% will not respond, so we have no treatment for them, no effective treatment, because we know what happens to the patient who fail on hypomethylating. The others will respond, so eventually we will have these patients with no treatment, and I'm going fast because I don't want to waste the time of the other speakers. Now, if we focus on the lower risk patients, again, it's a little bit more complicated. Some of them may be offered lenalidomide, others ESA, and then lenalidomide, imetelstat, experimental treatment, and others. But eventually, the bottom line is, and we went over and over again the numbers, and we can argue, but it's pretty similar, and we can say that after about between 6 months to 2 years, 30% have no effective treatment. After 3 years, 56% have no effective treatment, and obviously after 3 years, very few patients. And in fact, this is very similar to an excellent paper from the Ulrich Germing group. I haven't seen Ulrich if he's here. But they wrote several years ago that about 68% of the patients don't have effective treatment. So really, Houston, we have a problem. Now, these are, unfortunately, the only 7 drugs that have been approved by FDA over the last 25 years, and we are all familiar with these drugs, you know, hypomethylating, lenalidomide, luspa, imetelstat recently, and the decitabine, cedazuridine, only 7 drugs. And if we want to compare, you can see the other diseases. So, lymphoma, 17, multiple myeloma, 15, AML, 12, CLL, 9, MDS, only 7. So we are stuck and we have a problem. So in an attempt to answer this question, we asked 2 senior, well-known experts in the world, and they probably know the answers to these questions. So first, we will ask Amer Zeidan and then David Steensma. And this gives me a great opportunity to introduce a friend and a colleague, Amer Zeidan. Amer graduated medicine in the University of Jordan with honors, and then he moved to the USA. He was initially resident in Rochester, then a fellow in Hopkins, and in 2014, he moved to Yale, and it's unbelievable what Amer has done over the last 10 or 11 years. The list of tasks and jobs and titles is a very long list, and when I tried to get into the site and to see, it was truncated because, you know, after 250 words, you cannot see it. So I won't call all the list. I will just say that he's professor of medicine at Yale, chaired the Division of Hematologic Malignancies, Director, Hematology, Early Therapeutic Research Center, Assistant Director of the Clinical Therapeutic Office, and several other titles, but Amer will talk today about this issue of drug development for MDS with a special focus on high-risk disease. Amer, please.
Thank you so much, Moshe, for the kind introduction, and it's a true pleasure to be with you here today. This is a subject that we have been kind of talking about for, I think, for quite some time now, about, you know, the failures of drugs in high-risk MDS, and I think this is very important to discuss. So these are my disclosures, and this is where we are today with high-risk MDS, which is the focus of my presentation is going to be primarily on high-risk MDS. So this paradigm, compared to most paradigms in hematologic malignancies, has not really changed much, either transplant or hypomethylating agents. The only kind of major change was for the 5% to have IDH1 mutation is to give ivosidenib. But this clearly has been an area that has been quite challenging. And why is that? Because we know while hypomethylating agents have improved outcomes in patients, and azacitidine has been the only drug to improve survival based on the famous AZA-001 trial led by Dr. Finot, we know that HMAs have a lot of problems. Only half of the patients respond. Complete responses are less than 20%. Patients can take 6 months to respond, and the duration of response is generally limited to less than 12 months, no reliable markers for response, and once HMA fail, the median survival is very limited. And on top of that, we also know that the 24 months that have been shown in the AZA-001 trial has never been replicated in real-life analyses, even including at the level of big tertiary centers. These are 3 studies that we have done all the way between SEER registry in the US all the way to a consortium of centers in the US, and you can see the median survival range between 11 to 19 months. So most patients really live around 17 to 18 months with high-risk MDS. So it's truly a terminal disease. But why are we stuck with only azacitidine as a treatment for high-risk MDS? It's not for the lack of trying, I can tell you that. You can see here a very long list of trials. These are the only randomized phase 2 and phase 3 trials that have reported in the last 2 decades. And you can see they have been, primarily all of them have been negative, but in the last 5 years, I mean, we unfortunately have been stuck with a cascade of negative trials, one after the others. And the reason why I chose the title of my talk, The Boulevard of Broken Dreams, is based on a review or a perspective that was written actually by David Steensma and Mikhail Sekeres. Both of them are here. This was written in 2012 after the decitabine failure in AML, and they talked about the boulevard of broken dreams and how many trials have failed, because at that point in AML, more than 30, 40 years with no drugs. This was in 2012. So I don't think any of them, and I've never actually asked them this question, I will ask them afterwards, but I don't think they have imagined that 10 years from this editorial, we have 12 or 13 drugs approved in AML. And I'm hoping that this is what's going to happen in MDS as well. And I actually also didn't realize that, but the Boulevard of Broken Dreams is actually a song, and I listened to it today for the first time, and it's actually a pretty good song. They talk about measuring vital signs and CPR, and I don't know what, so you guys should listen to it. So this is a slide that I've been kind of updating every few meetings because the number of the failed trials. And what I will be doing today, and I don't intend to pick on any particular drug or on any investigator or any trial, but I'm going to talk about some of the common themes that we have seen across several phase 3 trials that I think, in my opinion, have contributed to why we have this repeated pattern of clinical trials. And I think there's always this discussion, or is the drug is the problem, or is the trial design is the problem? And I would argue that for several of the drugs that we have, probably it's a combination of both. I think the drug does have some activity, but as we will discuss, either it wasn't studied in the right setting, or there were issues with the design of the trial that did not allow the drug to kind of make it to the registrational approach. And of course, all of us are waiting for Verona. We are anxiously hopeful that this is actually going to be the trial that will break that cascade of negative trials. So some of the common themes in these pivotal phase 3 trials, and what's going to happen in the subsequent talks is that David is going to take a different take on this from kind of his new shoes in the industry, and Moshe is going to cover the lower risk primarily, but I think you will see some common themes. But I think some of the most important issues we deal with is how do we define the target population high-risk MDS? What is the definition of high-risk MDS? And do we underestimate early toxicity and the early discontinuation rate in those drugs when we go from phase 1 to phase 3 trials? How about the endpoint? Are we using enough statistical power when we power our trials to look at differences, or are we using what kind of fits the budget in terms of the sample size and then work it backwards? And how about TB53 high-risk MDS? This has been the most challenging subset. Should it be studied separately, or should it be included in the main trials? How about CMML, which has been historically included in trials for high-risk MDS? And how do you account for the issue of what we call intent to treat? Or for actually, once the trial is done, for how many patients have undergone transplant? And lastly, are we using the right endpoints? This is an issue that I actually spent quite a bit of time thinking about over the last few years, and I'm going to show some of my thoughts on this area. So for the first question, how do we define high-risk MDS? This is a subject that you have heard about, I think, a lot today, about the new prognostic models and the different definitions. But when you look across trials, you can see that different trials use different ways of defining high-risk MDS. For example, many trials have used any intermediate or higher revised IPSS as high-risk MDS. Other trials have required that the score on the IPSS-R to be 4 or higher. Other trials required more than 5% plus. Now we have the molecular IPSS, which again accounts for the mutations and defines higher risk as moderate high and very high. And even within the same drug, this is an analysis that Valeria presented a couple of years ago looking at the sabatolimab phase 2 and phase 3 trials. And even with the same drug, between the phase 2 and the phase 3, we have used different definitions for high-risk disease. You can see one dependent on the blast count and the other dependent on the IPSS-R score. And that can lead to significant shifts. When we looked at the different definitions of high-risk disease between the IPSS, the IPSS-R, and the IPSS-M, you can see the percentages change. So this, I think, is very important when you compare, especially between trials. But I think the most important question, which is many of us are trying to kind of think about from a trial design point of view, as it was pointed out earlier based on the very nice work by the IWGPM group led by Elsa Bernard about the biological subsets and the molecular subsets, and now we think of MDS as 16 different molecularly defined subsets. And rather than lumping all high-risk disease together in one trial just based on their risk, do we have to think biologically about treating patients who have common underlying biological and pathogenic mechanisms? Because this is probably what makes most sense, but is it realistic to do trials when you have these small subsets? I think it would be near impossible to try to do that. But this is, I think, one of the biggest challenges that we have in terms of how do we find the patients who go on trials. To the second point, I think about the issue of early toxicity. This is a problem, I think, that we have seen across a number of trials, and I'm going to give 2 examples here. One is the magrolimab trial, where I think in the phase 1, where the patients were treated in high volume tertiary centers where there's a lot of experience with managing anemia, some patients were hospitalized. The blood bank has a lot of experience in terms of finding the right blood for transfusions. So I think that toxicity was mitigated, but once this come to a phase 3 trial, where you have many centers across the world dealing with this, you can see the early discontinuation rate with this drug was much higher with the drug with magrolimab and AZA. It was 24% compared to 12% with AZA and placebo. So I think it's clear once you have significant early toxicity, or if you have chronic low-grade toxicity that leads to significant discontinuation, such as what we saw with the SWAG trial with lenalidomide and vorinostat, where you end up with lower chronic exposure of the investigational agent, that will lead probably to benefiting from the investigational drug and ultimately will probably translate into less chance of response. So I think this is an issue when we design our phase 1 trials. We have to be more cognizant of in terms of defining the right approach to manage toxicity and probably figuring out the right doses before we go to the phase 3 trial. About the size of the trials, this is an issue that I'm kind of choosing to show the sabatolimab trial for. What you can see to the left upper hand is the phase 2 trial with the progression-free survival trending in favor of AZA sabatolimab, and then the progression-free survival with sabatolimab, again trending in favor of AZA and sabatolimab. And then to the right upper hand, you can see the OS curves. And this is the closest we ever gotten to a positive phase 3 trial in MDS, where the median survival was 22 months compared to 18.5 months, almost 4 months difference in favor of AZA sabatolimab. So the question, again, everything is trending in the direction of the drug. So the question is, did we have enough power in this study to kind of detect the difference and whether having more patients would have saved this drug? I think this is an unknown question or an unknown answer in my mind, because the way we design MDS trials also takes into account the practicality of enrolling patients. Maybe in solid tumor trials, they are able to put 2,000 patients on a trial, but in MDS, putting hundreds and hundreds of patients can be tough. However, both these trials, the sabatolimab, the Verona trial, all these magrolimab, all these phase 3 trials actually accrued ahead of schedule. They accrued like very quickly because people are anxious to find new treatments. So I think we should be more ambitious and try to kind of power our studies to have statistically reliable estimates in terms of what we can achieve within the context of the trial. The issue of the TP53, so when we talk about TP53, we generally say it's around 5 to 10% of patients with high-risk MDS. But every single trial, and I can show you multiple in addition to the sabatolimab and the magrolimab trial, every single one of those had at least 20 to 30%. The magrolimab trial actually had almost 40% TP53 mutated disease, largely because all of us are anxious to put those patients on trials because they don't do well with our standard treatments. And I think what this ultimately leads to is this is a very difficult disease to treat, and it could mask the efficacy of the drug in the non-TP53 population. And what you can see to the right hand is the durvalumab randomized phase 2 trial. And you can see easily that the median survival in this trial with TP53 was almost 10 months, while TP53 wild was 24 months. And this is a trend we see in all trials. So I think in my mind, this argues for either separating TP53 by risk stratification within the trial or putting TP53 in a different basket. CMML, again, I clearly, different biology should not be part of MDS trials, but this has been done with the pivonidistat trial as well as the sabatolimab trial. And when you look at these graphs for overall survival, for both of those trials, you can see that CMML patients did not benefit. And that probably, when you look at the overall results, that skewed the results in terms of away from the investigational agent. And the issue of transplant, how many patients go to transplant after in MDS trials? I'm showing you here the phase 1 or the phase 1B of the venetoclax that just got published in Blood. And this trial has clearly shown that the median survival looks very promising with aza-ven. But what I would note in this trial is that 43% of patients went to transplant. This is a very high number. When you look at most of the phase 3 trials, like the sabatolimab phase 3 I just showed you, the transplant rate was only 10%. We generally get 5 to 10% if you are looking at truly real-life setting. When you look within this trial about the median survival for the non-transplanted patients, it was only 16 months. So this makes me worried about like what's going to happen with this combination if many of the patients on the trial were not transplant candidates. So I think it remains to be seen what happens with Verona, but accounting for the issue of transplant is very important. And the last point I wanted to kind of discuss in a little bit more detail is the issue of the therapeutic benefit. How do you measure therapeutic benefit in high-risk MDS? So we know it has to be either a hard clinical endpoint, such as overall survival, or a well-accepted measure for clinical benefit by itself. And the FDA actually has accepted durable CR and PR as an endpoint for approving a drug in patients with high-risk MDS. However, if we use a surrogate endpoint such as MRD clearance, it has to be validated in a stringent way. And so far, we don't have any MRD-based endpoint in MDS. However, measuring response in MDS is very complicated because the disease is very heterogeneous. It's also context dependent. As I discussed, like whether patients go to transplant or not, in the context of transplant, it might not matter as much whether you achieve a CR or not. And also the issue of the different classifications is complicating the issue of response assessment. For example, we have the new classification where patients with XS+2, 10 to 19% plus are classified as MDS/AML. And do you use AML criteria or do you use MDS response criteria in that setting? However, from the FDA perspective, and this is something I think I feel very kind of strongly about, the FDA has accepted complete remission that is durable as an approvable endpoint. This is what supported the approval for oral decitabine and cedazoridine and what supported the approval of ivosidenib. So we should not disregard measures of clinical benefits such as CR when we think about design and automatically assume it has to be overall survival. And actually, the FDA did their own analysis where they looked at a combination of trials. This was presented in ASH last December, where they clearly showed that CR and PR and HI, all of them basically associate with overall survival, although clearly CR had the strongest association. And people kind of dismiss CR because of the repeated failures of phase 3 trials. But what I can tell you is that there has not been a single phase 3 trial where there was a statistically significant improvement in CR that ended up with negative overall survival. The problem is that we do not get to the CR rate that we think we are going to get to. Here with the Apria, it was 33% versus 22%. With the tamibarotene study that just got published, was 23% versus 18% with AZA. So the issue is not that the CR was not good. The issue is that we are not reaching significant differences in CR. And CR has been actually shown, this is one meta-analysis that we published and others have shown similar results, that CR is a good surrogate for long-term outcomes, for survival in patients with MDS. And the FDA, again, I'm showing you here this press release for one of the menin inhibitors that I'm working with the company on, but in non-intensive chemo is a Venn-based approach, is in AML. The FDA has accepted CR and overall survival as dual primary endpoints. So CR, and I would assume it would be the same in high-risk MDS, that having a CR could be the foundation of accelerated approval as long as you have OS within the same framework of the trial. Now, aside from full CR, less than CR responses, what I would call having some meaningful count recovery in addition to blast reduction, this has been already used in AML studies for approval of IDH inhibitors, FLT3 inhibitors, and the FDA, again, I think is having an open mind. I think in MDS, this is something that we should discuss with them because the FDA actually generated this very nice analysis looking at complete response with partial heme recovery, CRH, and this was used for approval of drugs. So I think CRH or less than full CR responses, because they carry meaningful clinical benefit by themselves, should be a measure of palliative improvement that, in my opinion, should lead to drug approval. Also, CRs in MDS are very strict compared to CRs in AML. When you look at CR in AML, actually, they do not require a hemoglobin threshold. While in MDS, for a long time, we required having a hemoglobin threshold of 11. Now, in the 2023 criteria, we changed that to 10. But you can see the difference. If you look at CR by MDS criteria, it's 23% for this trial using VIXUS, When you look at it by AML criteria, where hemoglobin does not matter, is 52%. So you can see how big of a difference depending on which criteria do you use. I'm not going to spend much time on this, but MARO-CR has been, I think, a big problem of this movement from early phase to late phase trials. Magrolimab, for example, generated a lot of excitement because of the overall response rate was close to 80-90%. But you can see many of those were MARO-CRs, and MARO-CRs have not been shown in any context in a definitive fashion to associate with prolonged survival. The FDA did not even bother to put it in their analysis because they don't even accept it as an endpoint. So I think MARO-CR should not be included in any kind of response evaluation. You could argue whether this is something that can be done in the setting of transition to transplant, but it should not be a standalone approvable endpoint. And because of this, we developed the new response criteria 2023, which has been validated by multiple groups now, where we got rid of the MARO-CR. This is a validation by the Austrian group. We did our own validation within the International Consortium for MDS, showing that CR and less than CR responses are also beneficial in that setting. And there was actually a workshop led by the FDA that I think, based on the different stakeholders, including the investigators, and people from the NCI, etc., it was recommended that we should use these patient-centric 2023 criteria. And for the last half a minute, I'm just going to talk about some of the efforts we are doing within the International Consortium of Myelodysplastic Syndromes, trying to move the field forward in terms of agreeing on a consensus approach for trial design, harmonization of classification. This paper just came out trying to argue for a way to try to harmonize the clinical trial design in a way that is more patient-centric. And importantly, the patient-reported outcomes. This is in collaboration that will be with the MDS Foundation to try to develop a PRO score that would be similar to what is used in myelofibrosis trials to support patient-reported outcomes as a measurable and approvable endpoint in patients with MDS. And I would end by, can we exit the Boulevard of Broken Dreams? I think this is what we just did with AML after many, many years of waiting, and I'm very hopeful that we are going to do the same in high-risk MDS. And thank you so much for listening.
Thank you, Dr. Zeidan. I think please hold your questions to the end. I want you to stay at the end, and we will have Q&A at the end. I'll take the liberty to move on and to, I decided to take a little bit different approach, little bit overlapping, but take a different approach and to explore the way how drugs are developed in general, especially in cancer, and a little bit focusing on lower risk MDS. And this is just, we talked today about, and Dr. John Bennett received the Lifetime Award. This is a picture that given to me by John several years ago. This is the FAB, French American British Group, 1982, when the first time that the term myelodysplastic syndrome was suggested. You can appreciate this is John, Claude Sultan, Harvey Gralnick, and several other giants of hematology. But although we understand much more, in terms of treatment, we are still very poor. So let's move on and let's think about the way how we evaluate and how we develop drugs. And I'm not telling you anything new that you don't know, just to think about it. It starts with kind of basic research or an idea, animal experiments, and finally, we feel that we have enough data. And once we have enough data, we move on to clinical trials. 1, 2, 3, phases 1, 2, 3. And hopefully, if and when these trials are successful, the drug is approved, and then starts the marketing and using the drug in the market and the distribution. So this is the process that we are all familiar with. But however, when you dig in and try to see what happens in every stage, you will realize that there are some problems and things that we take as for granted. And I would like to focus on, I will not focus on the basic research and all these things, but I will talk about trials and about what happens in the post-approval period. And I'm trying now probably to share with you some thoughts about the process of clinical trials. Now, obviously, if the drug is not effective, there is lack of efficacy, or the drug is toxic, there is nothing to talk about. We are all in agreement. But what about other issues? So let's try to see there are challenges and limitations in clinical trials. There might be problems in the post-approval period, as I said. There is a gap between clinical trials and real world, and I'll focus on that. There is additional hurdles in real world. And obviously, I promised you to be more optimistic, and we will end up, like Amer, with some more thoughtful and optimistic suggestions. So what happens in clinical trials? I don't think that I have to show you this. This is every slide that every physician talking about MDS is using. And I'm moving on to challenges in clinical trials from the perspective of the patients. Now, our patients are older. We agree that it's better to stay younger, but what can we do? Our patients are relatively older. And by that, they have comorbidities. What does it mean? It means that, unfortunately, they are excluded from many trials. And if they are included in the trial, we will have to put up with the fact that there are several other problems, such as logistics. They are less mobile. They have lower tolerance to the treatments. They require dose modifications more than others, leading to protocol violation. There is a higher dropout rate, and it's less available. They are less available for long-term follow-up, which is much more important in patients with low-risk MDS, which is a kind of an indolent disease. Now let's move on and talk about challenges from the disease. And from the, I'm sorry, I think I missed something. Okay, I missed something from the disease. The disease is, there is a missing slide, but I can say that the main point is that the disease is very heterogeneous, as Amer mentioned, and obviously, talking about a very heterogeneous disease makes it very difficult. You know, at some point, I was so jealous at my colleagues from CML. They have a very simple disease. One mutation, one disease, one mutation, one drug, 96% response, and they are arguing between 96 and 94. We wish we were in the same situation. But unfortunately, our diseases are much more heterogeneous. Now let's move on and talk about the methodology of trials. And Amer touched it a little bit, and I will also touch it a little bit. Now, many of the trials, unfortunately, suffer from very complex design. Excessive regulation and administration requires administration, logistics, forms, and it becoming much more expensive for the companies and for others. Let's talk for a second about the inclusion and exclusion criteria. These are very important because it's enough if you decide on different inclusion criteria, and I'll show you some example, it may make the whole trial different. It may make the difference between successful and failure. And there are many examples. Now, endpoints. Amer talked about endpoints too. It's very important, endpoints and response criteria. And you know, I learned as a young doctor that if you have very long list of medications, probably none of them is really good. The opposite is also not a good one. And you see, in the past, in cancer clinical trials, it was much more simple. There was only survival. Then there was complete remission, PR, hematologic improvement, PFS, MRD, transfusion improvement, and so on and so on. And we really argue what's the best and what's the optimal endpoint, and we still don't have a good answer for that. And one of the proof why these trials are so complex, you can see the many adaptations and modifications during the trials, just to make the point that the trial, indeed, the design was complex. Now, let's say 2 words about statistics. Yes, we are all fans of statistics, obviously, but let's talk about some problems. unfortunately, because of the low incidence and prevalence of the disease, the samples are usually small. And the Nobel laureate Daniel Kahneman, psychologist who won the Nobel Prize for Economy, by the way, wrote a seminal paper in 1971 with his partner Amos Tversky, and the paper talking about samples, and he coined the term the law of small numbers. And indeed, if the small numbers are there, then you may draw a very different conclusion, which is not the right one. And I always remember my friend who used to tell us about a fascinating experiment with a new drug, but they did it first with mice. And a third of the mice, about 33%, responded very well. Other 33 did not respond, but the problem was that they could not get into conclusions because the third mice disappeared. So this is about statistics, and we have to be very careful with small samples. We tend to do subgroup analysis, not always the right thing to do. We tend to do partial post hoc analysis. We have no choice, but it may not be accurate. I want to say one word about the p-value, the holy word p-value, and the holy number 0.05. There is an excellent editorial in New England Journal of Medicine Evidence, Eric Van Sweet, and the title was Treat Patients, Not P-Values. And he explains very nicely how we as physicians were educated and trained in a binary way. Either the P is less than 0.05, successful, the drug will be approved, more than 0.05, failure, oi, oi, oi. And it tends to be that it is not really the case always, because and there are examples where it was not that statistically significant in the beginning, but it was effective and vice versa. And obviously, it might lead to misinterpretation. And now I would like to provide several examples that I found that might make these points a little bit stronger. There is a report from the NIH that evaluated several COVID trials. I'm talking now not about MDS at all. I'm talking about other examples. And they talked about COVID trials, and they had criticism about the designs of the trials and about the interpretation. The references are down. I won't get into details. There is a famous Alliance trial which tested the effect of aspirin in survivors of breast cancer, and this trial was defined as negative. However, editorial for the same paper went into the numbers and found that subpopulations indeed benefited from aspirin. I was familiar with many of the erythropoietin data about 10, 15 years ago, and as you all know, the oncologists with solid tumors, they don't use erythropoietin anymore. From their perspective, the patient can continue to be with hemoglobin of 7, 8, just not to give him erythropoietin because it may promote the tumor progression. Now, if you went over the data, you will realize that there are about only 2 or 3 papers that claim it against many others that were in the opposite side. And probably many patients who died earlier, this was because of the hemoglobin went up to 19 and 20, but they didn't care about it. So I'm not sure that the killing of erythropoietin was the right thing to do. Interestingly, about a year ago, there was a nice paper in Blood showing that another FLT3 inhibitor, sorafenib, together with chemo, was ineffective in AML. Probably this was the case, but Rich Stone, who wrote the editorial, pointed out that other FLT3 inhibitors were effective, including his paper in New England 1 or 2 years earlier, just calling for another attempt to test this inhibitor, and I'm not sure that this is going to be the case. Now, there are several other examples closer to us regarding MDS. Pevonedistat was discussed by Amer. I will not say anything about that. I will say something about the thrombopoietin receptor agonist. I was involved in some of these studies, and I can tell you that the suspicion that they may increase the blast count And Arigoanidis also wrote a paper about that, and I'm not sure that it is the right thing to say, at least in the lower risk. And unfortunately, we still have patients with thrombocytopenia, and we have nothing to offer them. Just one of them, for example, had intracranial bleeding, my patient last week, because she is carrying a platelet count of 10, 15, and I have no effective agent to suggest. Roxadustat. I know this study very well. The roxadustat study was defined as negative. Now, if we go into the details, the treatment arm had response rate of 47%, which is similar to most other trials, about 50%. The problem was that the placebo had 33% response rate, and the difference was not statistically significant. Again, the significant holy word. But if you follow the inclusion criteria, you would realize that almost every patient who required very low transfusion needs could be recruited. So if you have a patient who in January 1st receives 1 unit of blood with hemoglobin of 8, he's included in the study, and 2 months later he has the same hemoglobin and he does not receive any blood unit, he is responder, even if he's in placebo. So we know that, again, the inclusion criteria might be very important. Now, you may be familiar with the CC486, the oral azacitidine study, published in JCO. Guillermo Garcia Manero was the first author, and it was relatively successful. About 47% responded, but somehow it was stopped, and we don't have it for our MDS patients. It is approved for maintenance in AML. And when I approached BMS and tried to find out what's going on, I understood that indeed in the beginning there were some deaths, early deaths 16/6, but when they went into the details, they found that these patients were severely neutropenic, thrombocytopenic at baseline. So the protocol was amended according to that, and the FDA approved it, but somehow Celgene at that time, which was in contact with BMS, decided not to continue the development, and we don't have this agent for our MDS patients. There are other issues in clinical trials which we have to take into consideration. There are safety issues, and there are safety issues. The safety, obviously, is most important, but not always reported, and we have to take it into consideration. Amer mentioned the study that was published recently in Blood. The first author is Uma Borat, and they clearly showed that the safety and the inclusion criteria do not correspond with the right safety and the right toxicity that we know. They are usually more strict, and if we become less strict, we may include more patients in studies. And obviously the genetic, and I think just today, I think Seishi Ogawa and others showed that the genetics of patients from several other populations might be different. So these are all problems that we have to take into consideration talking about clinical trials. Now let's talk for a couple of minutes about what happens to patients and what happens to the drug after, if the trials are successful and the drug is approved. We have the drug, it is approved. But what then? There are several challenges here. We all know that real life is not really what happens in clinical trials. There is a nice paper that found that from the drugs for cancer that were approved in a fast track, when they waited for confirmatory trials, only 32% indeed showed survival advantage. There is a gap, which is called efficacy effectiveness gap, which we have to take into consideration. It was reported that in the US, only 7% of cancer patients indeed get into clinical trials. I presume that in most countries, it is even smaller percentage. And we talked about the inclusion criteria. There are certain populations which are underrepresented. Minorities, people with low income who cannot get to the third reference hospitals. So the clinical trials do not really reflect what we have. And the industry, sometimes, obviously, they prefer younger patients, healthier patients, and the follow-up is usually shorter than we would like it to be, and their results are superior, so what happens in real life is different. There are other issues, such as new safety signals, toxicity that was not reported in the trial, but it's reported later. And there is the limited commercial interest in disease, which is less common, small market, and slow development. Maybe David later will touch these issues. And we have to consider always the financial toxicity, because even if the drug is approved by FDA, it does not mean that everybody all around the world can purchase it, whether the insurance covers it or he can buy or she can buy it. So these are problems that are related following approval, if it is approval. So what can we do and what can we suggest? In the last couple of minutes, I will touch it very, very briefly. Yes, I believe that we can do better. And there are many suggestions how to do it better. Yes, we need the collaboration between the academia, the pharma, the regulatory, and the society. We need to have better biology, and we are having better biology because we hear it even today, and we will continue to have better biology and better understanding. We have to improve the trial design. Amer touched it also. The protocol should be simple. The criteria should be broadened. They will, I'm sure they will. And the patient identification enrollment can be better. And then the access in real world should be much larger. And the result, I hope, will be much better. With the interest of time, I will skip these issues. But I think there are several ways how we can improve in the next few years the trials and the post-approval period as well. So in summary, I was trying, I think, to convince you, and I'm not preaching for another system or another paradigm. That's not that I have a better paradigm to develop drugs. All the time saying that we as physicians have to be cautious, have to be critically in the good sense, and have to judge trials and what happens later in this way, and obviously to improve these points and these problems which I mentioned. And I apologize if I used some of my personal views and thoughts and shared it with you. So this is what happened to one of my patients who got a prescription and went to the pharmacy, and the pharmacist told him that there are no side effects, but the price may make him dizzy. And thank you for your attention. So with no further introductions, I would like to invite a friend and colleague, David Steensma. I met David several years ago, probably a long time ago, when he was still in Mayo Clinic. Then he moved to Dana-Farber, and where he did a great job focusing mainly on MDS. I don't know how many of you know that David was the first one to use the term chip that we are using here today all the time. I think it was in your Blood paper 2015. I remember that. It was a fascinating paper after the Ben Ebert and the other papers. And after 20 years in academia, David looks very young, but he was 20 years in academia. And then he moved to the other side. He crossed the street, moved to the other side. First, he was the global head of hematology in Novartis. And then about 2 years ago, he moved, and he is now the chief medical officer of Ajax Therapeutics, biotech company, which is developing drugs for hematologic malignancies. And David will tell us the perspective from the pharma, how he sees and how they see the issue of drug development. David, please.
Thank you for that kind introduction, Moshe, and for organizing this session and including me, including a industry voice. And also thank you to Arjan and to Saskia and Theo and the organizers. You know, it's always very fun for me to come back to the land of my Dutch and Frisian ancestors. This has been really an enjoyable trip. I want to start out, though, by highlighting that I'm giving an industry perspective, an idiosyncratic view held by me, and I'm not speaking for pharma broadly, or for big companies, or for small companies, although I've been, in one of each. But I do think, and I canvassed a number of colleagues in different companies, I do think there are some views on MDS drug development and heme malignancy drug development, generally that might be of interest to you. You know, we look at charts like this, and there's this old aphorism that comparison is the thief of joy, and we all have to follow our own path. I mean, if I went around every day and compared my career to Ben Ebert, I'd just feel bad all the time, right? So, but I think we can learn from those who've had huge success. Why have there been so many myeloma drugs? Why have there been so many new lymphoma drugs and we've struggled in MDS? Is it because they're smarter than us? Probably not. Is it because they got luckier? There is some luck, absolutely, in pharma. Is it because their diseases are just more tractable, they're more targets? I think that is a big part of it, and we'll talk about that in a moment. I think it's a lot of little things, some of which we can improve on, some of which are just intrinsic to the nature of MDS. I remember when I, as a first-year fellow got interested in MDS, I was working with Ailu Teferi out at Mayo Clinic, and I saw a patient with MDS, presented to him, and he said, you should work on MDS. He said, I've got myelofibrosis all covered. So you should work on MDS because, the only things we have are EPO and transplant. This was some years before azacitidine. And, we don't know what the genetics are. There are no preclinical models. There's no good biomarkers. We really don't understand how the disease works. So you should go into this because how can you make it any worse than it already is? So for other reasons, I did become an MDS researcher and clinical investigator. But I think he's right, even when azacitidine did come along, and I've used a lot of azacitidine and decitabine, as I'm sure many people in the audience have, I think the AZA-001 study was a little bit of an outlier. It certainly can be useful for some patients, but it's not so good that we can't improve on it. That said, it is a problem for us, particularly in the US, because the majority of patients start in community practices. They maybe get a cycle or two of azacitidine because that's what the doctor is comfortable with, and then they get referred to an academic center, to a place with clinical trials. But by that time, because they've had the azacitidine, they're not eligible for a clinical trial, and it's also, they've only had 1 or 2 cycles, so you don't know if it's going to work or not. So it really did put us in a bit of a bind. This is an update of a table that Dave Salmon and Zoe Z had in their ASH education book a few years ago, and I think a lot actually hinges on Verona. I think people in this room do appreciate that. If that's a negative study, it's going to be a huge setback for MDS drug development. Already, a number of companies just don't want to be involved in MDS. They see it as too high risk. They see it as too problematic, too many failures, and the juice isn't worth the squeeze. And I'm so hopeful for Verona. For patients' sake, I really hope this is a success, but it does face some uphill winds. Particularly around management of cytopenias. So, fingers crossed that will be the one that breaks this trend. Amer and Moshe mentioned a number of these problems around drug development that are concerns of clinical trialists, and certainly many of them are concerns among industry colleagues as well. Incomplete understanding of the disease biology, the lack of really tractable targets, kinase mutations are uncommon, whereas things like RAS pathway or TP53, which have been tougher, are relatively common. There's no undruggable target. I'm certainly a believer in that, but some are harder than others. There aren't really good biomarkers. Things that have worked in other diseases like immune checkpoint inhibitors or AML-associated mutation drugs really haven't translated very well. The preclinical models are really interesting, and they've illuminated specific aspects of disease biology, but they've been very difficult to use to predict what's going to happen in the clinic. I think the multiple classifications thing is a little overblown. I mean, yes, it was an own goal for the field. It did need to happen, but when we were developing trials with these two different classifications, you just kind of pick one and go with it. So I think it was more of a jobs creation industry for academics. A lot of people got a lot of papers and a lot of talks out of it. I think it really is a great thing that there's going to be harmonization, but it wasn't that big a deal. Same with response criteria. There have been a lot of different updates in the response criteria. I think this has really been more problematic in MDS-MPN overlap syndromes, where until fairly recently we haven't had good criteria. Now with the work of Michael Savona and others, we really have nice criteria for that group of diseases that we can use and regulators can hang their hats on. I think in MDS, the criteria have just gotten better and better, and many of the recent adjustments are to avoid things like what you talked about, Moshe, which is a 33% response rate in the placebo. I think a huge part, obviously, is the patient population. These patients, as you all know, tend to be older. They're frailer. A number of you have done studies. Rena Buckstein has really done a nice job at characterizing that frailty. And it just also makes it more difficult to get people on trials, to get people into clinics. Older patients, my parents are 80 now, they wouldn't want to travel to a clinic. They're happy with what they are. They wouldn't want to participate in a clinical trial, no matter how much my sister and I were to beg to them if they were diagnosed with one of these diseases. So that just makes it hard. I think we're also entering in a unique and difficult era right now. Regulatory agencies are very unpredictable. If you're developing a cell therapy or an mRNA vaccine, you had a heart attack this week when you saw that Vinay Prasad was appointed FDA's biologics chief. I mean, strict standards are great, but I think it's the unpredictability that's been difficult. And FDA has been so decimated by layoffs, I think we're going to start to see PDUFA dates not met more and more. Meeting requests are going to get pushed off more and more. It really is a difficult time. And we've seen even just a few hours ago a very prominent AML biotech company that was developing CD33 knockout transplants followed by CD33 CAR T has suspended all of their clinical development and laid off 95% of its staff. So I think that's the tip of the iceberg. We're going to see a lot more. On the positive side, biotech industry in China is really, really growing. And sometimes people come to me and say, what advice would you have for coming over to industry? And I always talk about how it's just like, you have to learn the craft. Even if you're already a clinical expert, there is things in industry around process that you have to learn. Maybe the advice I should start giving is learn Mandarin, because this is really going to be, I think, the future. I think the star is shifting towards where a lot of the clinical development is taking place. I think some of the things that are often thought of as industry concerns but really aren't are things like disease heterogeneity. Other than CML, all malignancies are heterogeneous, and we just have to figure out who the subsets of patients are and target things to them. The incidence and prevalence, these diseases are really very common, and if you can get an FDA-approved drug and do well for blastic plasmacytoid dendritic cell neoplasm, you can do pretty good in MDS as well. And the existing therapies, although they can be helpful for some patients, it's not that they're so hard to beat. In lymphoma, R-CHOP is pretty good, and so it's been really hard to try to improve on that. But AZA and decitabine, although they're helpful, it's a bar that could be surmounted. Take these market forecasts with large error bars. You can see how small the MDS market is currently compared to CLL, lymphoma, myeloma. That actually is a lot of incentive, I think, for companies. And a lot of companies talk about how MDS could be the next really big market if we can find things that work. So, that really is an area of some optimism. One of the things that I think has been really challenging is, and both of you guys alluded to it, this sort of law of small numbers or regression to the mean, where you see a very high response rate in 10 or 12 patients, and then sponsors have immediately moved to large trials. And to some extent, there is a need to do that. To get out ahead of your competitors, you do need to take risks in pharma. You do need to be willing to make some bold bets. But we've seen a lot of regression to the mean. We don't know what's going to happen with venetoclax, and I'll show you in a second some data around maybe better ways that we can be able to predict what's going to happen. So Andy Brunner had this idea. It was really fun collaborating with Andy at Mass General of working with a statistician and coming up with sort of receiver operating curve of where exactly is the bar when you see a response in 10 patients or 25 patients or 30 patients. What's the number that have to have a CR for there to be a reasonable likelihood that a larger phase trial is successful? And it turns out that most of the trials that went on to phase 3s would not have met this bar. Now, a few of them would have. For instance, the early reports of magrolimab had a very high complete response rate, and so it would have been well above this threshold that you would have predicted it was likely, and sometimes it just doesn't turn out that way. So, but we can think this through. I think there have been a number of errors by industry. Some of these have been self-inflicted, moving quite quickly, as I mentioned, from small studies to large ones. There's also been, I've noticed for a long time, long before I started doing anthropologic fieldwork in industry, that sponsors often really don't listen well to the community. There were sponsors that were just, there were things that weren't going to work in trials, and many people told them that, and they just went ahead with it anyway because it sounded good to them. There were also, I think, have been a lot of trials, and MDS is the same, of Me Too drugs. Pharma hates missing out. There's huge fear of missing out. If some company makes a big deal for a CD47 antibody, then everybody had to have one. So we end up having trials like, did we really need to test durvalumab, pembrolizumab, nivolumab, atezolizumab, all in MDS? Probably we didn't. It might have worked out different with one HDAC inhibitor versus another, but when you have all that redundancy, it ends up a lot of effort being concentrated in a relatively small number of targets rather than hedging your bets across a larger group of approaches. The trial design have been problematic, as was alluded to, and I think studies are getting a little better. FDA has certainly issued guidance to IRBs in industry around eligibility that have been helpful in some respects, but we've all had experiences where there were things in trials that were just, there's like one deal breaker with patient after patient that you see doesn't have a EGFR over 60, or their platelets are just too low, or whatever it is. And the dose reductions, I mentioned this in the context of Verona, it's really hard in MDS. It's one of the things I think that's made trials the most difficult. This was a nice summary, I thought, of why we don't have more drugs approved for MDS. And one of co-panelists was here. And I think there are some potential fixes to improve things. Allowing 1 to 2 cycles of an HMA for a high-risk trial and not excluding that certainly would help. That blast cutoff that both speakers mentioned it already, CRs, whether or not they should include hemoglobin levels, really focusing on overall survival, and not so much overall response rate. One of the things that's industry specific is that there's this tension in industry between process and disease-specific expertise. And so you often have people working on an MDS trial who last month were in the prostate cancer group, and the month before that were in rheumatology. And they can certainly bring some expertise around process to their new role, but sometimes it's problematic when they don't have a good understanding of the disease, especially if they're not willing to listen. The classic example of this is I remember getting a feasibility questionnaire when I was at Dana-Farber for a trial. And it was a drug that had been successful in solid tumors. It was an immune checkpoint inhibitor. And the study excluded patients with cytopenias. And that's not really going to work as an MDS trial. You can't be cytopenic and go on. And also required exclusion of CNS metastases. That's just somebody who, doesn't know the disease and move things along. Increasingly, companies are getting smart about this, and they're having checklists of common pain points. I have an ASCO education book manuscript about this with some colleagues from academia and pharma, and we had hoped FDA would be part of it. They actually started it, but then they were muzzled. They're not allowed to speak anymore, so they had to withdraw. I think also sponsors really talking to the community, and that community writ broadly, as you guys mentioned, including patients, including experts in various areas. That's really an important thing. Just the logistics with patients, elderly, coming from a distance. If you can do things locally, that's great. If you can do the kind of virtual trials that Uma Bharati has done for CCUS and colleagues, or Kelly Bolton for IDH inhibitors, rare subtypes, but doing it without having to come to a single center, that's really helpful too. And I think increasingly we're already seeing a shift, as I mentioned, China, but towards early development happening outside the United States. Most of the time, for multinational companies, trials will first open in countries like Australia, Singapore, South Korea, where they have a much more streamlined process for getting things. U.S. isn't terrible, but it is complicated, and EU is very, very complicated with all the data protection. So it's uncommon for trials to start here in Europe, and I think that trend is likely to continue. That's my daughter on a beach on an island in the north of the Netherlands, where some of her family members, including her namesake, are from. Again, thank you for the opportunity to speak with you this evening. Thanks for staying to listen. I know this is the end of the day, and hope it was interesting.
Thank you so much, David. We still have a few minutes for discussion and Q&A. Can we have lights in the hall, please? Okay. While you are making your way to the mics, David, I would like to ask you, obviously we are looking for win-win. We would like to convince the companies that the market is probably bigger than they think they are. And one of the ways to do it is indeed to start treatment earlier. And I think even today, I think this was Amit Verma and maybe also Sharam that convinced us that if you try to treat earlier, maybe before, you are not improving only the hemoglobin, but also the inflammation, the process. So what do you think, and how would you approach it? The idea, I know there is now BMS trial trying to use, I think, luspatercept before they are transfusion dependent. There is the Spanish trial that showed that you can delay transfusions in del(5q) with lenalidomide. There is the European study. We showed that you can delay the transfusion with ESA, but still, we don't do it in practice. So how can we approach, maybe this should be, a good number of patients that may benefit as well as the market will be bigger?
It's a great question, and I'll answer it in two different ways. One is that it is an attractive idea to treat earlier before clonal complexity has evolved further, before patients get sicker, performance score deteriorates, potentially additional comorbidities come along. So that's an attractive idea. It's equivalent to treating CML in chronic phase rather than accelerated or fast crisis, right? Which is a big difference. That said, I think it's an idea that has to be proven. There's a lot of controversy, for instance, around treating smoldering myeloma versus waiting until patients have overt myeloma, and the arguments for and against. The other way I'll answer, though, this is to say that duration for therapy is hugely important to pharma and to investors, because one of the things why MDS has been challenging is that a large number of patients who go on therapy are only on for 3 to 6 months, whether it's the newer therapies for low-risk disease or the time-honored now therapies for higher-risk disease. So that always goes into the calculation. It's not just the drug and how many people are going to take it, but how long are they going to be on it? If they're going to be on it for a median of 2 to 3 years, that's very different from 12 weeks. So if there are more effective therapies that make patients feel better and are attractive to be on for a longer period of time, that absolutely affects the incentives for sponsors as well.
So when you go back, you will tell it to your bosses in your company? Yes, please.
Those were terrific talks, everyone. They were really, really good. They were very provocative. Amer, I wanted to ask you to clarify something for all of us, and I know you'll come up with the answer so we can all move forward with great trials in higher risk MDS. You kind of played both sides of the coin. In one area, you suggested that we need to focus on overall survival and meaningful clinical outcomes for higher risk MDS, which we've been focusing on all along, right? And maybe the problem is that we're underpowering these studies. So again and again and again, if you look through these studies, we see an overall survival advantage of about 4 months, right? But we're powering these studies to see an overall survival difference of about 8 to 10 months. So I think one thing that we could do is really adequately power these studies and focus on overall survival. On the other hand, you talked about looking at interim markers of a clinically meaningful benefit. And I found this to be incredibly tricky within higher risk MDS. The AZA-001 trial, the CR rate to azacitidine is 17%. The pevonedistat study, when we had strict language in the protocol that you can't dose reduce, you got to stay on time, you got to give a bunch of cycles, the CR rate rose to 32%. So if you're powering a typical trial to show an improvement in CR rate at a power of about a 50% improvement, which is generally how these are powered, you're talking about attaining a CR rate of 48% in higher risk MDS, which I don't think I've ever seen. So what would you recommend? Should we go with more of an interim marker of a clinically meaningful benefit, get some combination out there on the market so we can work with it and refine it, or do we stick to our guns and stay with overall survival as a clinically meaningful benefit?
Yeah, I think you summarized both sides of the argument I was making very well. I think in my mind, we have moved from a situation where everybody was focused on what I would call suboptimal responses as a way of measuring benefit like Maro CR, all the way where we flip to the other end, where I'm hearing it more and more that the only way to get a drug approved in high-risk MDS is overall survival, which I think is clear from the FDA perspective that durable CR is not is viewed as both ends, meaning that it's a benefit by itself. A durable CR is a clinically meaningful benefit by itself that is enough to approve a drug without necessarily improving overall survival. So in my mind, if you have a drug that will statistically prolong the CR or increase the CR rate in a durable fashion. And this is why I showed the AML trial with the menin inhibitor, because the FDA did accept that as an endpoint in an unfit AML because of its palliative intent. They even accepted CRH in some setting. So I think that by itself could be an approvable endpoint. So if you have a drug where it's clear that the CR can be better, and again, you don't have the issue of regression to the mean. Let me put it this way. If you have an 80-patient study where the CR rate was 40 to 50%, which I think within the curves that David showed, I think you can power a trial like this based on CR, and then you have OS as a safety endpoint. You don't have to improve OS, but what I'm sure of is that the FDA will want OS as a safety endpoint, meaning that you're not improving CR and somehow worsening the OS. Now, if you have a drug where the benefit, and I think this could have been a situation with sabatolimab, for example, where the CR is not better, but some of your responses are less than CR, which the FDA will not recognize as a benefit by themselves. But if you have many of those patients who get some benefit, it would translate primarily into OS, then you have to do it by OS. So I think it really depends on the nature of the drug. Venetoclax, I think, is going to be a very good example. I think venetoclax beating on CR is going to be tough for different reasons because of the myelosuppression, the drug modification, etc. But that does not mean that you won't have OS advantage with it. So I think it really can go both ways. And the last thing I want to finish with is myelofibrosis, as we always discuss, they got approvals based on even patient-reported outcomes. We could not figure out how to do that in MDS, and I think that's partly on us as investigators because we did not develop the right tools.
Although I would argue with that, Amer, and you've heard me argue that.
What's your
before.
perspective, Mikhail?
So I would argue on that, and you've heard me argue this before, that while the FDA purports to approve things based on, it's either lives better or lives longer, right? Lives better. The drugs that have been approved based on lives better had objective measures of improvement, like MRIs of the spleen or gemcitabine for pancreatic cancer with less use of opioids. So I do think there's the potential there. I think we have to do it either with wearables, which is something that Rena Buckstein is pioneering, or somehow measuring time in clinic, time in hospital to go along with that. But I don't think duration of CR in and of itself is clinically meaningful to somebody unless they have improved patient-reported outcomes. So I think we need both.
Thank you, Mikhail. Please.
Thank you for this really important talk. So I think as well that there is a lack of medicaments for the thrombocytopenia patients, and that's
None, not lack, none.
There is no more research on that, or just less. So my question is, what can we do to change this? Because I think it's a really big problem. Like your patient with the bleeding, you see lots of those patients, or more of those patients, and we cannot really do anything at the moment except for writing off-label use letters to the insurance.
Yeah, I'll tell you what I think. It's indeed a matter of frustration. We are all frustrated because we see these patients and we cannot offer them anything. The only solution that I can see is really what we mentioned at the end, kind of collaboration. Convince the companies to develop, convince the regulators to be more liberal, and to come back to the pathway of development. That's the only way that I can suggest. I don't know, maybe David or Amer, can you comment on that?
Yeah, I mean, I think advances are going to come from advances in thrombocytopenia in other states, I think, other conditions. I think, we all recognize that when a patient is severely thrombocytopenic, especially once they become alloimmunized to platelet transfusion, it's a huge problem. And so we try to get them TPO agonists because, at that point, we don't really care if their blasts go up a little bit, if their bleeding risk is reduced. But I think it's such a small subset and a difficult one to work with that I think, sponsors are more likely to say, hey, this new pathway, whatever it is, worked really well in ITP, really worked well in chemotherapy-induced thrombocytopenia, then it could be repurposed for MDS.
Thank you. The last one, please.
Hi, I'm an MDS patient, and thank you for your presentations, because most of the issues that you've been raised are the issues that we are raising as patients. And I'm wondering if the fixes that you mentioned, you could add involvement of patients at the early stage in clinical trial or researches. Because even if we are old, our cognitive functions are still okay for many of us.
Absolutely agree.
Yeah, but maybe I'll start in Amer. It really has been, I think, very encouraging to see increasingly, even in early phase trials, sponsors reach out and include patients in the development. Certainly not every company, not every trial, but increasingly getting the voice of patients involved from a very early stage of development, I think, is important. When I was at Novartis, this became a standard thing. You had to include a patient group or a patient voice unless there was a reason not to, which was quite unusual. So I think we can only benefit from hearing what patients have to say.
Amer?
Yeah, I just want to add as a practical point to this. So the PRO instrument that we are working on, primarily by Rena Buckstein and Fabio Efficaci, and in collaboration with the MDS Foundation, is going to be developed by input from patients. So there's going to be a survey going to patients to rate what they value from their end as most important symptoms and things that should be focusing on, in addition to the functional components, how much active they are, etc. So I think this is going to be incorporated, but I do share the point that, or the concern about what Mikhail mentioned, is that while kind of historically has been always mentioned that patient-reported outcomes are something that the FDA would use if the patient lives better. How do you measure it, and whether they want objective evidence, like MRI showing a spleen reduction? I'm not sure how you can do that in MDS, in kind of maybe the wearables or some other functional kind of assessment, but that certainly is something that unfortunately we still have not developed a unified way of looking at this in MDS, and I do think it's important for the field going forward to develop some uniformly used instrument that can be incorporated in all trials that certainly will take the patient perspective.
Thank you, Amer. Maybe just to conclude in a positive way, thanks for asking, and I am sure, and I know, and I think everybody in the hall can agree that in contrast with the past, the patient's voice and the patient needs are taken into consideration today much more in the past. There is no trial that does not include quality of life issues and other initiatives to understand what are the patient needs. And yes, I believe that if we go along these suggestions that have been made here, the trials will be more appropriate, the results will be better, and I'm really optimistic. And I think that with this positive approach, I think it's time to end. I would like to thank very much Professor David Steensma, Professor Amer Zeidan. Thank you for joining us, and thank you for staying so late. Thank you so much.